So thank you, Milos, for this very kind introduction and for inviting me to give a bit of context to what we've heard before, this molecule which apparently is around despite what we think is a successful treatment to our patients, and we know it's a successful treatment, but probably can be still improved. And that's what I'll try to summarize in my talk. First thing is very obvious, but I'll try to support that with some more data and to make a point that low CD4 cell counts is bad. And that is something that continues to be relevant because I think it's 1 in 5 of our patients who does not achieve full immune reconstitution despite treatment. Immune reconstitution is challenging. We've tried different things in the past and they never succeeded. Sometimes they were even leading to worse outcomes. And our question is interfering with GP120 one way to improve this situation? This is cross-sectional data summarizing a very obvious thing that sometimes gets forgotten. A study that summarized the outcome of patients that, despite fully suppression of the viral replication, do not achieve a good immune reconstitution. They have still 10 years after treatment low CD4 cell counts, and you see the mortality risk increases as that CD4 cell count remains low. That, of course, is depending on advanced disease stages if you start treatment. So if you start with low CD4 cell counts, your risk of maintaining low CD4 cell counts is, of course, increased. That's nothing that I'll tell my patients instantly, but whenever I see some, and I do see them still every day, I think, what does it mean in the long term? Can we improve? Can we do something to them? Because it's not only the AIDS-related mortality that's increased. There's what's called here non-specific mortality. The AIDS-related mortality you see here in the middle, of course, is increased, but also death through other mechanisms and causes like COVID, like CMV, like tuberculosis, and other non-AIDS defining events is also increased. So there's an overall risk that could derive from many things. Inflammation, of course, is one of the topics that comes into my mind if I think about it. The infection process and the attachment and the fusion you mentioned already in your presentation before requires these different processes, and we can interfere, and we did in the past with different medications. And for Temsavir as a prodrug, so Temsavir is a GP120 blocker that interferes with this interaction as well. But on the viral side, the virus is the big brown enemy and the monster on the top right of the figure, as you can see here. And the drug was used, this is just quickly to remind you, in very important trials, the Brighty studies. There's 2 different main studies. The top one you see, patients which are heavily treatment experienced were then randomized to receive here in the early phase for Temsavir versus a placebo to see the activity of Temsavir here as an antiviral drug in isolation, and then they were continued to receive, they were continued here to receive an optimized backbone on top. And the non-randomized cohort in the bottom part of the slide you see received the same drug but without any randomization. It got for Temsavir and an optimized backbone right from the beginning. These 2 cohorts, or these 2 groups and studies, were slightly different. As you can see here, the prior treatment and the options and the exhaustive classes of antiretrovirals were different. As you can see in the randomized cohorts, most of the patients, or many, and now the pointers unfortunately disappeared, you see, had options. At least integrase inhibitors were active in a significant proportion. The red one represents the non-randomized group, and these were really heavily treatment experienced patients with very little options. The same is shown on the right-hand side. You see, for the randomized and non-randomized group cohorts, again, particularly for the non-randomized, that the majority of patients, more than 80%, had no active other component, fully active component that could be used in the optimized backbone. Still, if we look in the virological response rates in both groups, remarkable outcomes after 2 years, week 96, you see response rates with full suppression, slightly more in the randomized cohort, but up to 80% and up to 60% after 2 years, also in this non-randomized cohort, where we think the Temsavir and partial activity of the optimized backbone contributed to this effect. So that's the primary goal, that's the primary outcome, that's what we want to achieve. But what about other outcomes? CD4 cells, which are important, as I said before. And you see that here also for both cohorts, same colors. The non-randomized cohort slightly less, but we do see immune reconstitution. Not in all patients, of course, but despite these heavily treatment-experienced patients with low CD4 cell counts of less than 150 on average or less than 100 in both cohorts, there is improvement. And very interesting, because these patients are heavily treatment-experienced, they also suffered, unfortunately, of course, during the study period, from outcomes, from morbidity and mortality. And it's interesting to see that the CD4-CD8 ratio, if you look in the analysis, was predictive for the outcome. So there was, compared to a CD4-CD8 ratio of 0.3, compared to 0.45, there was a major difference. If you remained in this low strata, in the low area, your risk of getting complications and mortality was increased. If you managed to get out of this and get into this greener zone, then the clinical outcome also in these studies was improved. Again, showing virus suppression is important, immune reconstitution is another important component of reconstituting health and preventing outcomes. And this is a summary of the many ways how the immune system, and mainly indirect causes, lead to loss of CD4 cell counts. So I remember 15 years, 20 years ago, we taught our students CD4 is a very important entry mechanism for HIV, and HIV infects the CD4 cell counts, and that's why we lose them. Now we think it's probably more indirect mechanisms why we lose CD4 cells in our patients. And it's lots of pathways, apoptosis, paroptosis, necroptosis. I don't go into all this, but that's the idea. If we can interfere and prevent this loss, and if it's mediated through GP120, then this could be beneficial. You've seen these data before. I just want to highlight this again. I'm not sure whether the pointer comes back. For some reason, I'll try this again with a laser pointer. Here we go. You see, that also makes sense. If you've got viral load detectable, then you've got GP120 detectable. That's easy to understand. But look at this patient here. Viral load is fully suppressed. GP120 is maintained over time. Here again, another situation, while you suppress viral replication and the viral load goes down, of course GP120 goes down. But here another patient where you see GP120 is maintained despite full suppression of replication. That's not the case in all patients. That's not the case in all samples. It also depends on the mechanisms and the tools that you use to measure GP120. But more recent data, very sophisticated technical approaches from the Lichterfeld group that looked into the reservoir, tell us that if we think there is no new virus being produced and HIV RNA is undetectable, there could be still some incomplete production, not of infectious particles, but of viral proteins and products like GP20 that are active then and can be produced and released from cells. In these analyses, you see here on the right-hand side, up to 25% of those people where they looked with very sophisticated ways into the reservoir, there was evidence that partial sequences of these latently infected cells could be able to produce viral products and viral proteins despite there is no viral replication detectable in the periphery. And also, this is what's been shown before, GP120 could then act on myeloid compartments, on myeloid cells, and what I wanted to stress here is then the release of cytokines, and that was in these experimental conditions, depending also on the interaction with CD4. So mechanistically, it would make sense that this is something that is happening through these mechanisms that we propose to be active. And it's not only CD4, we all know that co-receptors are involved in the entry as well. And this is going again back into data that were published a while ago. You see here CD4 again as a co-receptor, as a main receptor, and CCF5 as a co-receptor. And of course these chemokine receptors are important and signal as well. And the binding and the attachment of GP120 also leads to signaling through these pathways, as being shown here on the right. So if there is interaction of the protein with the signal in the wild type situation, there's a lot of gene transcription, as you can see here, everything in red. If that is a different co-receptor than the tropic virus for CCF5, doesn't work anymore. And if you've got a cell system that doesn't use CCF5 as a co-receptor, then there is no transcription. And these transcriptions and factors and targets are also involved in gene cycling and inflammation. Again, showing it's receptor depending and could be a rather specific effect in contrast to unspecific effects. So in summary, I think there is some evidence to suggest that the primary virological and secondary effects persistent of inflammation impairs CD4 cell homeostasis. The question to me is, why isn't that the case in all patients, and what distinguished the one from the others? And that the HIV and viral proteins, including GP120, may be able to contribute to this significantly despite full virus suppression. Thank you.